evening, everybody. Thank you very much for joining us. Today's evening session is entitled Treatment Planning Made Clear in Neuroendocrine Tumors and Pancreatic Cancer, Personalized Integration and Validated Emerging Therapies. So first of all, I'd like to introduce myself. My name is Simron Singh. I'm a professor of medicine at the University of Toronto. I have two amazing colleagues with me today, Dr. Daniel Ann from the Mayo Clinic in Arizona and Dr. Nitya Raj from Memorial Sloan Kettering. Specifically, thank you to PeerView for hosting this evening seminar, and specific thank you to both Let's Win and NCAN, both tremendous organizations, for providing this session, and of course to our grant sponsors, Exelixis, Ipsen Pharmaceuticals, and Novartis. There is a pre-event survey that you can do, and also we'll have some polling during the presentation, and as we go through, I'll explain that a little bit more. You can submit your questions, and we have an iPad, and we'll have time for the question and answer sessions for the panel to go through that. For those people in the room, you can use your personal device to scan the QR code and respond to the questions and to ask faculty questions. And for those watching virtually, you can respond to the polls on your screen and enter questions in the chat window. So this is the QR code, and this is for those people in the room. You can use that QR code. Hopefully that's at your seat. That should take you directly to the questions, and there's actually an incentive for those people in the room. If the more questions you ask, the more you have a chance to win a $50 gift card provided by PeerView, and if you do, you can talk to one of the PeerView people to avail yourself of that. Again, this is put on by PeerView, an excellent source of medical education for both clinicians and patients. This is a QR code if we need more information, and you can see their socials as well as their contact information here. After this presentation, the slides and practice aids will be available for your download for you to review in your own time. So let's get right into it. Our goals for today are to hopefully improve your understanding of the current diagnostic tools when it comes to neuroendocrine and pancreatic cancers, to improve and to discuss the latest clinical evidence and practice guidelines that are emerging in the options of neuroendocrine and pancreatic cancer. Fortunate to say we're seeing a lot of progress in both these areas. Provide you with tools to help customize your treatment plans for both neuroendocrine and pancreatic cancer patients that not only consider the latest evidence and guidelines, but are person-centered and consider specific patient characteristics that will help guide your treatment. And finally, we want to be able to come out of this with enhancing our skills and increasing our comfort with person-centered care, AI management, as well as clinical integration for these diseases. Okay, so we're going to start with the neuroendocrine cancers. Now, neuroendocrine neoplasms are a very diverse group. Now, all malignancies, of course, are diverse, but I will say that neuroendocrine neoplasms are unique in that they can really arise anywhere in the body. They arise diffusely and have a very heterogeneous pathology and clinical course. As many of you may be aware, we have very slow-growing, more indolent type cancers to very aggressive cancers such as small cell lung cancer type. The other unique things about neuroendocrine cancers is they have the ability to secrete amines and peptide hormones, which can lead to hormone excess, which may or may not cause symptoms, but can cause complications nonetheless. Now, initially people thought neuroendocrine neoplasms were a rare disease, and that certainly has been shown to be not true anymore. The graph here shows you the incidence of all neoplasms in the SEER database in the blue line, and then you could see, of course, taken to scale, the brown line here of neuroendocrine neoplasms. And in fact, as this has been updated in upcoming publications, I can tell you it continues to rise. The incidence is rising in all sites, including the lung, small intestine, rectal, and pancreatic net. And the incidence is increasing at all stages and grades, unfortunately. However, the most notable rises have been in localized and low-grade disease. That may be with the introduction of more screening programs, as well as more early detection. Now, as I mentioned, a very heterogeneous group of tumors that we're dealing with here. Neuroendocrine neoplasms today are primarily graded according to differentiation, which we talk about as morphology, and grade, so their proliferation index. So the first thing we do is we think about neuroendocrine tumor versus neuroendocrine carcinoma. Neuroendocrine tumors are well differentiated. And I'm no pathologist, but you can see from the slide there, you can see the difference between that and a poorly differentiated neuroendocrine carcinoma, which looks a little bit more angry and proliferative. When it comes to grading, We then further divide this, especially the well-differentiated neuroendocrine tumors, into 3 grades based on Ki-67, which is a proliferation index. And again, hopefully these slides demonstrate to you the difference in proliferation between grade 1, grade 2, and grade 3. In 2019, the WHO reclassified the GI and pancreatic neuroendocrine neoplasms, as I mentioned, into well and poorly differentiated. The difference here is previously grade 3s were automatically assumed to be poorly differentiated. But as I mentioned to you, differentiation is about morphology and grade is about proliferation. So a new category of neuroendocrine tumors called well-differentiated grade 3 neuroendocrine tumors were introduced into the system. We base this all on the Ki-67 proliferation index. It can be less than 3, 3 to 20, or greater than 20. A poorly differentiated neuroendocrine carcinoma is almost always certainly a grade 3. Now, as I mentioned, we need to keep our eye out for hormones. Not all neuroendocrine tumors secrete hormones. Not all neuroendocrine tumors secrete hormones, but some may. And that depends on the site of origin. We have neuroendocrine tumors, we still look at the embryonic origin from them, from the foregut, the midgut, and the hindgut. The midgut, of course, being the small intestine neuroendocrine tumors, the hindgut being the rectum, and the foregut primarily being the lung, but also the stomach and the proximal duodenum. The midgut neuroendocrine tumors primarily will secrete serotonin. The foregut tumors can secrete ACTH or histamine, especially with the lung neuroendocrine tumors. However, they can also secrete serotonin. Pancreatic neuroendocrine tumors, as you can see here, can secrete a variety of hormones, including insulin, gastrin, glucagon, VIP, somatostatin, and this can have a variety of different clinical symptoms in the patients that we see. Endoscopy plays a role, as I mentioned to you. Local disease, grade 1 disease, is the fastest growing neuroendocrine tumor. And as you can see here, whether it be rectal nets or small gastric nets, endoscopy certainly plays a role. We do have to be cautious when we're getting pathology, in that sometimes we get a fine needle aspiration, and that may not be adequate to determine the Ki-67. Video capsule endoscopy can be used for small bowel nets, although the sensitivity and specificity are somewhat less in surgery and can, of course, have a complication of bowel obstruction. CT and MRI are still our mainstay for use when it comes to both diagnosis and staging for neuroendocrine neoplasms, especially the GI tract. And so we'll stop here. If you want to take a few seconds just to scan this QR code, you'll see some follow-up questions, and you can answer them on your devices. And for those at home, you should be able to hopefully see the questions. So as we're doing that, one of the new areas that we continue to see growth when we talk about neuroendocrine tumors is somatostatin receptor imaging. So somatostatin receptors, there's 5 of them. Somatostatin receptor 2 is present on the surface of the vast majority of the well-differentiated neuroendocrine tumor cells in the GI tract. That is helpful to us from both a diagnostic and imaging perspective, but also from a therapeutic perspective, as I will talk about. Right now, we do a PET imaging using a tracer. The common PET imaging tracers are 68 gallium, whether it be dotatate or dotatalk, and more 64 copper dotatate being used. Lesions are considered SSTR positive if its uptake is higher than the background liver. Now, adding this to conventional cross-sectional imaging can help improve the diagnosis and staging biomarkers, we are working very hard to try to improve our work in biomarkers. Traditionally, our only biomarker has been chromogranin A, which has its limitations. It could be prognostic, but it rarely defines treatment decisions and sometimes can actually cause more anxiety than it's worth. And many clinicians now are not following that. But we continue to look at strategies not only to measure serotonin in those tumors that are secreting, but also looking at ctDNA, circulating tumor cells, etc. And I'm confident that hopefully in one of the future meetings that we meet, we'll have more to report in terms of advances in this area. Now, it's very important with this heterogeneity of tumors that we put the patients in the center of our care. This is a diagram from our cancer center where we have developed a program to ensure that we have a lot of multidisciplinary care as well as case conferences that develops an individualized treatment plan combining the very many different modalities we have with the principle of putting patients at the center. And that's going to be some of the theme of what we talk about tonight, is how these different treatments can improve patient outcomes and tailor treatments to individualized patients. And as we talk about supporting our patients, I think, again, it really bestows us to talk about the excellent work that some of our patient advocate groups are doing. NCAN has a communication with patient support program, as well as helping clinicians communicate with their patients, and they have their information here, so please do visit their website or scan the QR code, as well as Let's Win Pancreatic Cancer, again, helping patients find clinical trials, find the right patients, and ensuring that they can get assistance with the navigation, which can often be complex. So kudos again to both these amazing organizations. Okay, so that hopefully has given you a whirlwind tour of neuroendocrine tumors and neuroendocrine carcinomas. Maybe what we'll do now is we'll start talking about the treatment now that we've talked a little bit about the diagnosis and the heterogeneity. So, when we think about neuroendocrine gastrointestinal nets, that's primarily thinking about small bowel and rectal neuroendocrine tumors, so not including pancreas or lung here. For well-differentiated gastrointestinal neuroendocrine tumors, it's difficult to define a specific algorithm because many patient characteristics come into place. But what we do know is that unlike many other cancers, even if complete surgical excision is not possible, surgical debulking can be beneficial, both to increase the time to progression, but also to help deal with the overflow of symptoms and of peptide secretion. In some low-volume disease, given that if it's a low-grade tumor and we know that the proliferation index is low, we may elect to watch and wait and to follow these patients closely without having to intervene just quite yet. But in other cases where we have lots of disease burden or aggressive biology, we may want to be more aggressive and consider frontline systemic therapy or local regional therapy. What could those therapies be? Well, generally, as I mentioned, primarily we see SSTR2 expression on the vast majority of the well-differentiated neuroendocrine tumors, and that's why we often start with a somatostatin analog, usually being octreotide or lanreotide. Now, recently, we have seen some evidence for frontline PRT, especially in those neuroendocrine tumors that are a little bit more aggressive, the higher grade 2s and the grade 3s based on the NETTER-2 clinical trial. So we may think about using PRT up front for our patients to provide them the best outcomes. And there are certain clinical trials now looking at higher dose SSAs. Beyond that, we think we have a number of new treatment options, some of the most exciting ones being cabozantinib that we're going to talk about today. We also have other clinical trials that are available. And for those patients who have on somatostatin analogs and then have progression, generally based on the NETTER-1 clinical trial, which I will discuss, as long as they're SSTR positive, we may consider PRT with lutetium dotatate. Now, superimposed on this, of course, is the hormonal secretion that we need to keep in mind. So again, when we're treating neuroendocrine tumors, we have two goals in mind. One is to control the cancer, and one is to control the hormones. And for controlling the hormones, we have a number of options. Local regional therapy, we think about things like embolization, etc. But also we have new medications like talotrostat and other systemic therapy being developed that is helping to help us manage the patient's burden with symptoms. Pancreatic neuroendocrine tumor is similar but slightly more complex. There's slightly less evidence for resecting metastases in primary and pancreatic neuroendocrine tumor. With the small bowel neuroendocrine tumors, resecting the primary is quite important in many cases to prevent obstruction. Here, we may also consider it asymptomatic if it's lower volume disease, although generally we may be more inclined to treat, given that we know pancreatic neuroendocrine tumors are a little bit more aggressive and a little bit more sensitive to treatment. But again, we have the options that were described, somatostatin analogs, upfront PRRT for the slightly higher Ki-67, and then progressing to receive treatments such as cabozantinib or PRT after that. So how do we make these decisions? Well, we're going to discuss some of that today, but just as a general theme, of course, we said we want to put patients at the center of our decision-making, things like age, comorbidities, and performance status. But all these disease-related factors that I described are very important in helping us understand, where does the tumor start from? Is it a GI? Is it a pancreas? Is it a lung neuroendocrine tumor? The differentiation in grade, of course, will make a very big difference. The level of SSTR expression and that dual PET imaging can potentially help us. And then, of course, the clinical behavior. That will probably be the most defining feature, the pace of disease progression, which sometimes we can't predict with the limited predictive markers we have now. Of course, symptomatology will be important, and we want to make sure that we are addressing the symptomatology as well as any risks that may occur from excess hormone secretion. So I'm going to talk a little bit about a case now and maybe get our panelists involved. This is Richard. He's a 65-year-old gentleman who presented with a well-differentiated neuroendocrine tumor. The pathology revealed, as I mentioned, well differentiation, but a Ki-67 of 20%. So this falls into this new category that we are talking about, this just on the cusp, but on this new category of well differentiated grade 3 neuroendocrine tumors. Previously, we thought grade 3 neuroendocrine tumors were by definition poorly differentiated, but we realized that over time that this isn't the case. And so what we are dealing with here is a tumor group that is still well differentiated, but has a higher proliferation index. And this would be indicated as manifested by the extensive liver metastases that Richard unfortunately presented with. As I mentioned to you on the previous algorithm, we often think about potentially any surgical debulking or surgical intervention, and this unfortunately was not a case where surgical resection was possible. In addition, I mentioned we always have two goals, dealing with the cancer and dealing with the hormones. And fortunately, in this case, there was no symptoms or hormone excess that would indicate this is a functional NET. So this would be a non-functional NET. So how would you approach first-line treatment selection for Richard, and what options would you choose? So maybe before we go into some of the evidence, Nitya, do you have any initial thoughts that come to your mind? Limited information here, but.
Yeah, I mean, this is a case that we're now seeing commonly, I feel, in clinic, especially with kind of the reclassification pathologically. I mean, the big things when I meet a patient like this in clinic that I'm thinking about are, ideally we'd have the information from the dotatate PET. So you'd want to know if the disease is somatostatin receptor positive or negative, and that's probably going to guide your initial treatment approach, but there's sort of probably three things you're thinking about. Maybe a somatostatin analog, although I know we'll talk a little bit more about that in someone who has absolutely no symptoms versus radioligand therapy. And then the other thing is if someone is highly symptomatic, now it sounds like this patient is not, and you need to start therapy really, really quickly, you may actually think about chemotherapy in this case because you can get that started the next day.
So I think that's a really important point, is part of it is what's best for the patient and in terms of getting their treatment, and then what is feasible in terms of the pathways. Daniel, did you have any other comments that you wanted to add?
Yeah, I think Nitya raised some great points. Like the first thing is, symptomatology. Is this somebody who needs potentially more aggressive treatment to get cyto reduction if you decide treatment, or is this potentially somebody that can have more disease stabilization with therapy? And then even though this patient potentially may not be a surgical candidate at this time, there are more and more data to emerge about potential role for liver transplantation. So even though the patient's not an upfront surgical candidate at this time, I think liver transplantation is something to consider down the road, right?
Great. Okay. Thank you. So let's talk. Nitya mentioned maybe potentially somatostatin analogs. What's our evidence that would drive this? Well, there's two main trials to date that have defined somatostatin analogs as one of the bedrocks, I would say, for our treatment of our well-differentiated neuroendocrine tumors. One was the PROMID trial, which was released in around 2008, I believe. This looked at octreotide LAR, 30 milligrams every 4 weeks versus placebo. A small trial, less than 90 patients, only done in Germany. A limited patient population with midgut neuroendocrine tumors. They were functional and non-functional. Octreotide scan positive at 74%, which makes you wonder about the other 26%, and mostly had a low Ki-67. This was a investigator-initiated trial, so we don't have all the data we would like, but it did show an interesting improvement in the time to progression from 6 months to 14.3 months for a hazard ratio of 0.34, pardon me. So clearly there seems to be disease arrest when we start on the PROMID trial. But what we do see here that there was very little response, and that kind of goes along with what we know about somatostatin analogs, that they're cytostatic and not cytocidal, as opposed to some of the other therapies we might talk about today. The CLARINET trial expanded on this using a similar agent but a different somatostatin analog, lanreotide versus placebo. This was a global phase 3, a much larger trial published in the New England Journal. It compared GI and pancreatic neuroendocrine tumors. They were all non-functional, all SSTR expression with a Ki-67 less than 10%, and again showing a positive hazard ratio of 0.47. So somatostatin analogs clearly work in well-differentiated neuroendocrine tumors. But what about, is that the ideal treatment? Well, we did, and we're going to talk about the NETTER-1 clinical trial. But what was interesting is the control arm of the NETTER-1 clinical trial was a high-dose octreotide arm of 60 months, and that showed a PFS of 8 to 9 months. So there has been some thought that maybe escalated SSA dosing may still be beneficial for select patients. With the CLARINET trial, there was a sub-study that looked at the CLARINET Fort. These are patients who had progressed on standard dose lanreotide that they were then in a single arm given higher dose lanreotide of 120 milligrams every 2 weeks. We don't have comparative data, but we do know that in about 25% of the small bowel tumors and about 1/3 of the pancreatic neuroendocrine tumors, in 1 year they had stable disease. So in some patients, there may be some benefit for higher dose somatostatin analogs. And there is a trial being done right now called the Sorrento trial, which is examining a investigational agent called CAM2029, comparing it to standard dose SSAs to look at progression-free survival in GI neuroendocrine tumors. We anxiously await the results of this trial because this may again change the landscape of somatostatin analogs overall. CAM2029 is a high exposure self-administered SSA. So that's the SSA. What about, Nitya brought up radioligand therapy or PRT. Well, this has really revolutionized the care of neuroendocrine tumors as we know it. For those who aren't aware, radioligand therapy really is like a lock and a key model is how I think of it. You have a receptor, an SSTR receptor, that then binds to a ligand with a decaying isotope, in this case lutetium-177, although there's other agents coming out like actinium-225 and lead, which is alpha radiation. This then binds to the tumor cell, the tumor engulfs the compound, and then over the next weeks to come, radiation is emitted from this isotope, killing the tumor cell and hopefully protecting the healthy tissue. This is as close to a silver bullet as we get to in neuroendocrine cancer because we have a nice target of SSTR2 receptors, and it's systemically giving small particles of radiation. This is a really new and exciting way of treating cancer overall. We traditionally think of cancer treatment as systemic therapy, radiation therapy, and surgical therapy. This is really going beyond that and going beyond the pillars that we have, and it's certainly expanding into many other areas beyond neuroendocrine cancer. So as I mentioned, the first time that we showed radioligand therapy to be effective was the NETTER-1 clinical trial. This was published in the New England Journal of Medicine. This trial looked at patients who had midgut neuroendocrine tumors who would progress on standard dose somatostatin analogs. They were then randomized to receive 4 cycles of lutetium dotatate concurrently with octreotide LAR versus, as I mentioned, the high dose octreotide LAR. You can see here the results, fairly groundbreaking here, a hazard ratio of 0.21. That's a 79% reduction in the risk of disease progression or death. And I won't hesitate to say if this was breast cancer or another common cancer that we see, this would be on the front page of the New York Times, this would be on the front page of Time magazine. But this is a pretty significant advancement when we think about treating our patients. What was also important is when we think about our cancer patients, we're obviously trying to increase quantity of life, but we also are thinking about quality of life. And lutetium dotatate's impact on quality of life was actually one that improved quality of life. So often when we see a therapeutic agent, we want to make sure we're not worsening our patient's quality of life. In this case, giving the patient the therapeutic agent actually improved their quality of life by a global health status that is commonly used in clinical trials. Beyond midgut neuroendocrine tumors, there is data to show that this may be effective as well as pancreatic neuroendocrine tumors, and certainly in most regions of the world, that's where the label would go, is that it's available for GI neuroendocrine tumors. for those patients who are SSTR positive. We have a little bit less data with the bronchial or the lung neuroendocrine tumors, although trials are currently underway to try to understand what role PRRT may play in those patients who are SSTR positive lung neuroendocrine tumors. But currently, it's really the GI neuroendocrine tumors where we can make an effective mark with this treatment. So we know that neuroendocrine tumors that have progressed on somatostatin analogs seem to respond well to radioligand therapy, lutetium dotatate. What about frontline therapy? What about for these more aggressive patients, as I described, someone like Richard, who has a higher proliferation index, and we may not feel comfortable at treating this patient with only a somatostatin analog? This was the NETTER-2 trial that looked at 226 patients who were generally treatment naive. They were then randomized to receive lutetium dotatate plus octreotide LAR or high-dose octreotide LAR like the NETTER-1 trial. And these were patients who had a higher grade 2 or grade 3 disease, still well differentiated, but a higher proliferation index. When we look at who was enrolled on this trial, what we can see is generally these had a mix of approximately 1/3 to 2/3 for the grade 2 disease. There was a mix of pancreatic as well as other midgut tumors, but about half of them were pancreatic neuroendocrine tumors, which makes sense. Much like Richard, we know that pancreatic neuroendocrine tumors can present with this disease, a high degree of metastatic burden in the liver, in the bone. And what's key here is they were all SSTR positive. So that's key when it comes to radioligand therapy. The patients have to be SSTR positive for this treatment to be effective. When we look at the results of the trial, we again see curves that nicely separate and stay separate. You could see here the median PFS in lutetium dotatate arm was 22.8 months versus 8.5 months in the control arm. This was again a very positive trial that showed us that for these patients there's definite benefit with a hazard ratio of 0.276. What was nice about this trial is that we haven't seen high overall response rate. So in somatostatin analogs, we show that we've been able to stop the disease that's cytostatic. What we saw here was some of the highest response rates we've seen in neuroendocrine tumors today, with an overall response rate of 43%. And that means we're killing the tumor cells, and that could be very beneficial when we start to think of bulky disease and disease where the bulk of disease or the location of disease is causing symptoms, and even possibly things like mesenteric or peritoneal disease. When we look at the safety, we see the common safety we know with RLT. The nausea, the vomiting generally can be associated more with the amino acid diffusion than the treatment itself. There was some hematological toxicity. Most of the hematological toxicity, about 80% of this, can be expected to recover within a few months. But we do need to keep track of what we call myelodysplastic syndrome, which somewhere has a 1% to 2% rate, which can, if unchecked, can proceed to a leukemia. So we do want to follow that toxicity. And certainly now we are getting more and more information from centers such as Nitya's about understanding who is more at risk for potential long-term bone marrow toxicity with radioligand therapy based on chip analysis and other things, as well as sequencing and how that might affect things. Now, when this trial came out with a high response rate and as well as the improvement in the progression-free survival, there was some debate. Well, maybe it's the grade 2s, those slightly less aggressive ones that are responding, not the more aggressive ones. Then some people thought, well, maybe it was the grade 3s, the more aggressive ones that are responding better, that's driving this benefit. So when we did a formal multivariate subgroup analysis, we actually saw that this benefit was maintained both in grade 2 and grade 3 neuroendocrine tumors. As you can see here, the curves remained separate and the hazard ratios were positive for both those subgroups of patients that I was talking to you about. When we looked at as well as the site of origin for the pancreatic net and the small intestine net, we know that there's more patients who have high-grade neuroendocrine tumor with the pancreatic net. But clearly here, it is again seen that this effect of radioligand therapy, lutetium dotatate, is beneficial right across the pancreas as well as the small intestine net. The NETTER-P trial looked towards, in our younger patient population, those that were 12 years old and older, a very small study, but nonetheless was looking for safety signals and did not show any worrisome safety signals for the use of lutetium dotatate or Lutathera in those patients who were younger. And so based on this, there was FDA approval given last year for pediatric patients 12 years of age and older. And I think we'd be amiss if we didn't talk about where we're going with radioligand therapy. So we've talked a bit about post-progression, check We've talked about, for those more advanced disease, early treatment or treatment naive patients. We've shown an effect there, check. What about in those patients who have lower proliferation index but may have more bulky disease or a higher disease burden, a fair amount of liver disease or large lymph nodes? What about them? So this is a trial called the NETTER-3 trial now, which is starting to get in place. We expect the first patient to be enrolled hopefully sometime this summer. This is looking at advanced or metastatic newly diagnosed G1 or G2, so those are patients with a Ki-67 of less than 10%, with a high disease burden and a SSTR uptake. And these patients are being randomized to receive Lutathera as frontline therapy versus traditional octreotide LAR, and the endpoint will be progression-free survival. So again, this will help us completely understand where radioligand therapy, in this case lutetium dotatate, may be beneficial for our patients. What about if one cycle is good is more better? Well, there's also a number of trials going on forward in retreatment. This is the NET Retreat trial run by the NCTN and NIH, led by CCTG and SWOG. This is looking at patients who've had a durable response defined as 12 months of disease arrestment between the completion of lutetium dotatate and progression. And these patients are then being randomized to receive lutetium dotatate versus everolimus. Hopefully there's a protocol change going through in this to allow this to go forward with pancreatic patients, as well as also allow for cabozantinib given its use now in neuroendocrine tumors. There's also looking at alpha therapy, a very similar trial, the ACTION-1 trial, slightly different in that it looks at alpha therapy rather than beta therapy as a retreatment strategy, and it has a slightly lower disease stability threshold of 6 months. So what I would really call the NET Retreat trial when it comes to retreatment, we're really looking at the long responders, and for ACTION-1, we're looking at the non-resistant patients. So let's go back to Richard's case. We have a 65-year-old gentleman who has a grade 3 well-differentiated neuroendocrine tumor, not eligible for surgical resection, no symptoms. We've talked a little bit about the upfront treatment. Nitya, do you want to comment a bit more? We really are thinking about SSA versus PRT here, or are there any other options that we can also think about?
Yeah, so in a patient like this who is asymptomatic but has kind of very high disease burden and high-grade disease, kind of given the data from NETTER-2, this is a patient that I would almost certainly have the discussion about radioligand therapy up front.
And how does tumor grade factor into your decision, Daniel? Is tumor grade, does it drive your decision making when it comes to something like this, or?
Yeah, I think it's an important thing to take into consideration, but not for this patient specifically, but even if a patient has grade 2 or grade 3 disease, if they're well differentiated, I still think SSAs would be appropriate if they're asymptomatic. And then the one question that we talked about earlier, the point that we discussed was a consideration for chemotherapy, especially based off the Alliance trial, and that's ongoing to look at potentially sequencing as an option. So we don't have that answer yet, but I think chemotherapy is another reasonable option as well.
Yeah. Hopefully we'll get more information as we come along. And then the other thing to consider would be this gentleman, if maybe he had a lower grade disease, lower Ki-67, but still this high burden disease, may be a good candidate for this upcoming NETTER-3 trial as well. So we have another case here to quickly, as we sort of think about this. This is Joanne, who's a 55-year-old patient diagnosed with a midgut neuroendocrine tumor. SSTR imaging was done and showed extensive SSTR expression. She has adequate bone marrow, renal, and hepatic functioning. Again, Nitya, how does the site of origin affect your treatment decisions? And given that she has adequate bone marrow, renal, and hepatic function, does this open up the doors a little bit to maybe your treatment of choice?
Well, so I think something that we have to keep in mind, site of origin is very important if you can identify that at the time of diagnosis. We know, and we'll come back to this in the next part of the talk, that for our midgut patients, we're more limited in the tools that we have for those patients. And in general, the response is not as robust to all the tools that we have. So this is someone where you want to really try to extend your use out of all of the therapies that you have. So in someone like this, with midgut disease, somatostatin receptor positive, overall fit and healthy, I would probably try to start with the somatostatin analog first, see if I get mileage out of that therapy before jumping right into PRRT.
And what would you do once they have progression on the somatostatin analog?
Yeah, so once they have progression, that's a great question, and I think that where the progression is a very important thing to think about. And the way I break it up is is it liver-only progression in patients who have metastatic disease versus someone who has extrahepatic progression as well, because I will try to maximize my use out of liver-directed therapies as well if it's really liver-only progression, and then kind of think about some of our other systemic therapies next after that.
Okay, we'll end this with a polling question that people can do, and you can scan either at home or over here. And remember, the more questions as well you ask. And as we move forward, we've talked a lot. As much as I love SSTR2 receptors, we're fortunate we're at a time in neuroendocrine tumors where we can start thinking beyond that, and we haven't really talked yet about targeting agents and the role of TKI. So I'll hand it over to Nitya to talk about that.
Thank you. So I think that this is a good segue into kind of one of the other buckets and therapies that we have in this disease, and a lot of excitement given the recent approval of cabozantinib. So I'll be focusing this next section really on the targeted agents and expansion of receptor tyrosine kinases to treat neuroendocrine tumors. So as a framework for this next portion, I'm just going to present this case of William, and then we'll come back to it a little bit later. So William is a 50-year-old patient with pancreatic neuroendocrine tumor who is progressing on upfront therapy. So William is a patient with well-differentiated advanced pancreatic neuroendocrine tumor who actually received initial therapy with a targeted drug called everolimus, which is an mTOR inhibitor. And so now he's presenting to meet with you in clinic with signs of disease progression, and we need to think about the next steps in his care. So I just want you to keep these questions in the back of your mind as we start talking a little bit more about our other options to treat this disease. And those questions are, what subsequent treatment options would you consider? And is there a role for other molecularly targeted agents? Okay, so in terms of molecularly targeted agents in neuroendocrine tumors, I really think of two major buckets. And so the first one is kind of our drugs that target mTOR, and in specific, that primary drug is everolimus. The second bucket is the tyrosine kinase receptors, and so those are sort of multi-targeting drugs which act on several different signaling pathways, and the ones that have been studied in neuroendocrine tumors include cabozantinib, lenvatinib, surufatinib, vitalinib, pazopanib, sunitinib, sorafenib, and axitinib. And so the idea behind these targeted drugs is that they're attacking signaling pathways that we believe are in overdrive and contributing to the pathogenesis and development of the disease. So a role for everolimus to treat both extrapancreatic and pancreatic neuroendocrine tumors came out of the RADIANT-2, the RADIANT-3, and the RADIANT-4 studies, which are highlighted in this slide. And in all studies, patients were randomized to receive either everolimus at a starting dose of 10 milligrams per day with octreotide LAR in RADIANT-2. Those patients had carcinoid syndrome, or everolimus alone in the RADIANT-3 and the RADIANT-4 studies. And patients were randomized to receive everolimus or placebo in all of the studies. And so what you can see kind of looking down at the curves is that there was a significant PFS benefit demonstrated in all of the studies. But importantly, and sort of what I want to highlight here, coming back to sort of the stabilization of disease that we predominantly see with a lot of our therapies, there was kind of very limited objective response. And so the majority of the patients who responded to everolimus really saw stabilization of the disease. So moving now from everolimus, which is the one drug that we have to target the mTOR pathway, I'm now going to spend the next few slides talking about some of our other multi-kinase inhibitors. And the one that's kind of most extensively used prior to the approval of cabozantinib is sunitinib. This is a drug that was studied specifically in pancreatic neuroendocrine tumors in this key clinical trial where patients with well-differentiated pancreatic neuroendocrine tumors with progressive disease were randomized to receive either sunitinib or placebo, with the primary endpoint being progression-free survival. And so in this study, what was observed again was a significant improvement in progression-free survival with a median PFS of 11.4 months in patients receiving sunitinib compared to 5.5 months in the placebo arm. Again, kind of looking at the response rate, the majority of the patients who responded, again, were largely having stabilization of the disease. There was sort of a limit in terms of the partial response rate. It's from this study that sunitinib gained the FDA approval for treatment of pancreatic neuroendocrine tumors specifically. So serifatinib is another multi-kinase inhibitor that was studied in 2 pivotal trials, the SANET extrapancreatic or EP trial and the SANET pancreatic or P trial. And so in these 2 studies, again, a progression-free survival benefit was demonstrated for the use of serifatinib over placebo. Now, unfortunately, this study was primarily conducted outside of the US, and so given kind of the patient population that was enrolled in this study, this drug did not receive FDA approval, and it was the studies were open around the time of the COVID pandemic too, which limited the ability for them to include other sites. So while this drug has gained some approval outside of the US, this is a therapy that we don't have access to in the US. So kind of quickly going through the other trials that have evaluated tyrosine kinase inhibitors in neuroendocrine tumor. There have been a few largely phase 2 studies that have looked at pazopanib, axitinib, that was a phase 2/3 study, and then lenvatinib. And while these were all slightly smaller studies, again, a progression-free survival benefit was demonstrated for the use of these various tyrosine kinase inhibitors in neuroendocrine tumors with varying sites of origin. So kind of in that background, and at the time that the cabinet study opened, the primary kind of receptor tyrosine kinase we had for use to treat neuroendocrine tumors was sunitinib, and that was really for the pancreatic primary neuroendocrine tumors. And so the cabinet study looked at a drug called cabozantinib in all grade, well-differentiated pancreatic and extrapancreatic neuroendocrine tumor. And so cabozantinib is a multi-kinase inhibitor of VEGFR, MET, AXL, and RET. And in the cabinet study, patients with well to moderately differentiated neuroendocrine tumor encompassing all grades in the more contemporary World Health Organization criteria were randomized to receive either cabozantinib or placebo. It was a 2-to-1 randomization, and I think very importantly in the study, patients were stratified by site of origin, and so there were 2 arms. There was the extrapancreatic neuroendocrine tumor arm, which included all sites of origin outside of the pancreas, and then there was the pancreatic neuroendocrine tumor arm. Coming back to the eligibility criteria, all of these patients were previously treated on a prior FDA-approved systemic therapy that did not include a somatostatin analog. So these were patients that were heavily treated. And actually, when the study opened, it was around the time that lutetium dotatate gained sort of the FDA approval. And so many of these patients that went on study had also previously received PRRT, which I will come back to. The primary endpoint of this study was progression-free survival, and the secondary endpoints were overall survival, objective response rate, safety, and tolerability. So looking at baseline demographics and clinical characteristics for the population included in the cabinet study, again, there were 2 cohorts, the extrapancreatic cohort and the pancreatic cohort. And so what you can see, and I think what's actually really important to highlight here is that again, patients of all grades were included. In particular, we had a fair number of patients in both cohorts with grade 3 disease. And there was very good representation from the extrapancreatic cohort for patients that had tumors originating outside of the small bowel. So definitely included patients with lung primary, thymic primary, other, and unknown primary disease. Looking at prior therapies, again, this is a very heavily pre-treated population. So most of these patients had received somatostatin analog therapy. Many patients received PRRT, everolimus, and there were a cohort of patients who had also received chemotherapy, and some pancreas patients who had actually received sunitinib. So going to the primary endpoint of median PFS, and so what we saw in both the extrapancreatic and the pancreatic primary cohorts was a progression-free survival benefit with the use of cabozantinib over placebo. And so in the extrapancreatic cohort, there was a median PFS of 8.4 months with cabozantinib compared to 3.9 months with placebo. In the pancreatic primary cohort, the median PFS was 13.8 months with cabozantinib and 4.4 months with placebo. And this is kind of a similar theme that we've seen over the years in studies that have looked at targeted agents in this disease, that we tend to see more robust and durable responses in our patients with pancreatic primary disease. So while pancreatic primary tumors often tend to be more aggressive, we can kind of get more response from the therapies that we have available. So kind of looking at the subgroup analyses in both cohorts, what you can see is even when you kind of look at the various subgroups by tumor grade, differentiation, functional status, age, the benefit of cabozantinib persists across all of kind of the subgroup analyses for the extrapancreatic cohort. And similarly, that same benefit of cabozantinib is seen in the pancreatic primary cohort. So really, we're seeing a benefit of cabozantinib across prior therapies and across sort of tumor grade and functional status. So objective response, and as I had mentioned when I first started this section, in the prior studies with everolimus, sunitinib, one thing that we commonly see in this disease is that often while we kind of get a response, that's usually stabilization of the disease, and less commonly are we seeing shrinkage of the disease. But what we saw in the CABINET study is that there were a cohort of patients, particularly in the pancreatic primary cohort, where you clearly see a confirmed response by RECIST. And so this is an important point because sometimes with our targeted drugs, we think that they're really good to use in lower volume disease where you're kind of just hoping to stabilize the tumor. Maybe it's just grown a little bit, but cabo is certainly a therapy I will sometimes turn to when I'm actually looking for a little bit of shrinkage, because that has been clearly demonstrated in the CABINET study. And so treatment-related adverse events, and I think this is a really important topic for all of our targeted therapies, and in particular something that I will have a discussion with patients when I start cabozantinib, because we know there can be some side effects with this therapy. However, if we're proactive, and if patients are also proactive to let us know if they're having any of these side effects, we can often control them very, very well, and patients can really tolerate the drug quite well. And so when we think about the most common side effects with cabozantinib, similar to some of our other systemic therapies, fatigue and some of the GI side effects are ones that we will commonly deal with. Something that the patient doesn't feel, but I will say, as I've been using more and more of this drug in clinical practice, you can definitely see the liver function tests go up a little bit. You can have some issues with the blood counts, and especially in our patients who have been previously treated with some of the other therapies, including radioligand therapy, you have to be very mindful about the blood counts and keep a close eye on them. Hand-foot syndrome is a side effect that can be seen with this therapy, and with proactive use of topical emollients and steroids is something that we can actually manage very, very well. And then I think the other big one is hypertension or elevation of the blood pressure. And so for patients who have a known history of high blood pressure, I will ask them to keep a closer eye on their blood pressure at home for the first few weeks. Let me know if it's going up at all, because with proactive adjustment of the antihypertensive agents, we can kind of minimize our need to play with the doses too much. One thing that's not on these slides, but I did want to mention, is in the CABINET study, while the starting dose was 60 milligrams, the average dose that most patients received was actually just under 40 milligrams. And so there's been a lot of discussion amongst the neuroendocrine community in terms of what's the right starting dose of this drug. I think that some certainly start at 60 milligrams and are very comfortable doing dose reductions early if needed. Others will start at 40 milligrams, and we can definitely see efficacy at that dose, and sometimes hope that the patient may just be able to maintain that dose without too much adjustment of the medication. So I think both are potentially appropriate options that all of us are using with this drug, and I think as we use it more, we're just going to get more comfortable with the dosing of the medication. So back to William's case, in terms of considerations for integrating targeted agents. So just as a reminder, William is a 50-year-old man with moderately differentiated, advanced and progressive neuroendocrine tumor of pancreas primary. He initially received everolimus, and so now he presents with disease progression and is here to discuss the next options in treatment. So really we'll focus the next few minutes with my colleagues on the panel about considering initiation of treatment of William on cabozantinib. So I guess I'll start with Dr. Singh. Maybe you could walk us through kind of when in the treatment course you think about the tyrosine kinase inhibitors, and how do prior therapies perhaps affect that decision?
Yeah, thanks. That's a really good question. I think when we talked about molecular targeted agents, we really had everolimus before, and although, as you showed in the RADIANT-4 studies, that seemed to have some benefit, I think what we realized, especially as we had real-world evidence, was just how burdensome the toxicity of that could be on our patients. So the introduction of cabozantinib has really been welcomed, I think, by the neuroendocrine community to be able to treat our patients effectively, and also, as you mentioned, with proactive management, the toxicity is probably preferential. The other thing that I keep in mind is we had talked a little bit in the previous section about radioligand therapy and the role of the possibility of myelodysplastic syndrome. And what we're finding out more and more now is sequencing may be important. Sometimes we use alkylating agents such as temozolomide in treatments of our pancreatic neuroendocrine tumor patients, and data out of Australia at the Peter Mac and as well as out of the Moffitt Center has shown that potentially those patients, when you use back-to-back alkylating agents and RLT, may increase the rate of MDS. So I think cabozantinib also could play an important role earlier in the treatment algorithm to prevent the back-to-back treatment of those in sequencing. So I think more and more, to answer your question, I think when we think about the convenience to patients, the ability for it to be able to control and in some cases shrink the disease, good toxicity management, as well as reducing the risk of MDS, I think it's becoming more and more earlier in my treatment algorithm.
Yeah, I would completely agree. And then one thing that I do want to emphasize is that, cabozantinib, as I mentioned in the CABINET study, all patients had to receive a prior FDA-approved therapy, either PRRT, everolimus, or sunitinib. However, the FDA approval was really for patients who had received prior therapy. So it's a lot more open in terms of kind of our access to the drug. And so I guess with that in mind, I guess, Dr. Ahn, how do you think about cabozantinib in earlier lines of therapy?
Yeah, I think it's a good question. So to Dr. Singh's point, I mean, when you look at the RADIANT trials, a lot of patients were actually censored out. So I think the PFS benefit's often overstated, and a lot of it has to do with treatment tolerance, and especially when you reach out to our community colleagues who treat an occasional neuroendocrine patient, they're very skeptical to use everolimus and sunitinib even more. And so with a drug that they're very familiar with using cabozantinib, they're likely to use it much more earlier. I have a lot of experience because I also treat HCC. And so I very often use cabozantinib at a 40 milligram dose, and they're very comfortable adjusting those dosage. And then, especially with this patient, as Dr. Singh mentioned, the risk for MDS or any kind of myelodysplastic disorder, especially somebody who's 50 years old, their lifetime risk is much more higher.
Mm-hmm.
Our group published a meta-analysis kind of looking at the risk for any of these hematologic disorders with any kind of radionuclide therapy, and that's something that has to be taken into consideration. If this patient was in their 70s or 80s, I would say, yeah, no problem, you can consider jumping earlier. And the last point I wanted to make is access to radionuclide therapy too. So oftentimes I do meet with our community colleagues where they often just use TKI after TKI after TKI just because they don't have access to these treatments, where in an academic center you're more likely to pull the trigger to use a radionuclide therapy like PRRT or a clinical trial like with the alpha particles much more sooner.
Yeah, I think that all of those points are well taken. And, as as unfortunately we're seeing more and more younger patients being diagnosed with cancer and GI cancers, and we're seeing this in neuroendocrine, I think that the point about some of the bone marrow issues is really important to keep in mind as we're thinking about sequencing these therapies, because I too sometimes am thinking about cabozantinib a little bit earlier in my younger patients if I feel that maybe I don't need to pull the trigger on radioligand therapy yet. I have a little bit more time. It's a therapy that I am moving to sometimes earlier. And so I think that's a very, very important point.
I think just to add, I think sometimes it's also patient preference, right? I think as Daniel alluded to, sometimes if RLT can only be given at certain centers, and sometimes patients prefer having an oral therapy, care close to home, care in their home, and that makes a big difference as well.
Totally. And I think the other thing that's so important about CABINET is because we have the data for use of this drug in well-differentiated high-grade disease, I think that, all of us have a lot of comfort that this is a drug that potentially will have efficacy in that cohort, which really we don't have that data with some of our other drugs. They were almost certainly included in the other studies, just the classification was different, but it's information that we can share with our patients when we're walking through the different options that we have. So quickly, like in our last minute, I kind of mentioned the options in terms of dosing this drug. I know you had said, you often start at 40. I will say I generally start at 40 milligrams daily, and I tend not to escalate because I find that people are able to maintain that dose well, and we can manage the side effects. I guess, Dr. Singh, how do you usually approach the dosing?
Yeah, I think one thing to keep in mind is not all toxicity is the same, and as I think you mentioned in your talk as well, like this is a drug where most of the adverse events are manageable with proactive management. So in those patients, especially for those where I'm looking for a bit more of an aggressive response or shrinkage, I start at 60 milligrams, and of course, if need be, we dose reduce. At some patients, you're right, where I may have a bit more concern, I do start at 40 milligrams, but I generally try to dose escalate up to 60 if I can, and really as much as it works with the patient, yeah.
Great, okay. So if you can, scan this QR code, and then there's gonna be a few questions that come up in this section of the session. Oops, sorry. And so kind of just to summarize, and our take-home messages from the neuroendocrine portion of this talk. So hopefully, I think everyone in the room can appreciate that we have a lot of different systemic therapy approaches to treat advanced neuroendocrine tumors. The tools that we have in our pocket include the somatostatin analogs, octreotide and lanreotide, targeted agents, predominantly now everolimus and cabozantinib, although we do still have sunitinib, chemotherapy options, which we didn't touch up too much on this talk, but that are certainly there, and then of course PRRT, primarily right now. 177 lutetium dotatate is the FDA-approved radioligand therapy, but a lot of important studies ongoing with alpha emitter therapy. When you're thinking about your choice of treatment and approach to treatment, we have to think about the patient characteristics, the disease characteristics, and what your goals are with therapy. Are you looking for shrinkage? Are you looking for stabilization? Are you primarily trying to control the hormones? What is the goal? And that will help guide you in terms of the right first treatment, second treatment for the patient. A multidisciplinary approach to care is critical. Dr. Singh highlighted the multidisciplinary team and DMT that they have at their cancer center. Similarly, we have a multidisciplinary team at our institution, and we meet weekly to review patients and cases because there's not one right decision most of the time, and so it's very, very important to lean on the expertise of your interventional radiologists, surgeons, pathologists, nuclear medicine doctors, and other oncology colleagues to guide your treatment plan for patients. I think this is a very, very exciting time for neuroendocrine cancers. The treatment options are expanding. NETTER2 and CABINET now open up some additional therapies for our disease with the option of frontline PRRT for our higher grade patients and cabozantinib for our previously treated patients of varying site of origins. So as we look to future studies that are ongoing, we continue to look for novel agents to treat this disease. A lot of work work are going into predictors of response and resistance to therapy. And really, I think the focus right now in the active studies is trying to better sequence the therapies that we have so we can extend our use for our patients.
All right, perfect. So we're going to move on to talking about pancreatic ductal adenocarcinoma. If this was 5 years ago, this talk would be about 5 minutes, but unfortunately a lot's changed in the field, so we'll kind of go through some of the new treatment options as well as those that are going to be emerging in the near future. So let's first start with a case scenario. So Stephen is a 50-year-old patient who initially presented with constitutional symptoms including unintentional weight loss, decreased appetite, and weakness. He goes to the hospital, gets admitted, and upon his hospitalization, he undergoes further workup where imaging noted that he had multifocal liver lesions as well as a mass on the pancreatic tail. He goes an ultrasound-guided biopsy of one of the liver lesions, which unfortunately confirms adenocarcinoma consistent with a pancreatobiliary primary. So let's just pause here. So just to summarize, newly diagnosed metastatic pancreatic ductal adenocarcinoma, all his labs look within normal limits, nothing that's overly concerning. So how should we proceed with this patient's care? So when you look at the guidelines, it's similar to the guidelines we talked about with neuroendocrine cancers. The guidelines really just provide, options in terms of treatment. I think when we think about the focus, really the way I think of, when I think about treating these patients, I kind of think about them, how clinically symptomatic are these patients? Meaning, are they a patient that has a good performance status? Or are they someone that has a heavy symptomatic burden to where your concerns is about them to be able to tolerate treatment? And especially in the setting where the goals are truly palliative, there's a balance between impacting their quality of life as well as providing life-sustaining or life-prolonging therapies. And so when you look at the preferred regimens, they include FOLFIRINOX, gemcitabine, nab-paclitaxel, and now NALIRIFOX. While those with the intermittent PS, you may consider chemotherapy, chemo monotherapy, or some of the other less intensive options. So here are the key 3 first-line studies. Again, this is just to highlight and not to compare the efficacy of these 3 results. Initially, we had the results from the gemcitabine nab-paclitaxel, which was presented and published in 2015-2016. On the left, we have the FOLFIRINOX, and most recently, we have NAPOLI-3. So looking at 3 different studies, looking at really, which I think the one consistent take-home is that if a patient is able to tolerate either a doublet or a triplet over gemcitabine monotherapy, that should be the standard therapy. So the NAPOLI-3, which was presented a few years ago by Zeb Weinberg at ASCO GI, this study looked at comparing NALIRIFOX, which looks at giving nanoliposomal irinotecan in combination with 5-FU and oxaliplatin compared to gemcitabine nab-paclitaxel in those with advanced, untreated, newly diagnosed metastatic pancreatic ductal adenocarcinoma. And the study met its primary endpoint that showed an improvement in overall survival compared to the doublet, as well as an improvement in progression-free survival. But just as a caveat, the study really aimed to compare it as a doublet, and it didn't really aim to compare to FOLFIRINOX. So mainly the take-home from the study was that, based off the results, it does appear that a triplet would be more beneficial rather than the doublet. We are going to see some updated overall survival results presented at this year's ASCO, so we can see whether or not these overall survival changes. But here we have at the time of the initial presentation and publication. And so one of the concerns that we often have with giving nanoliposomal irinotecan, or also known as NALIRI, is really the toxicities. And so as part of the subgroup analysis, they went ahead to look to see whether or not in patients that had severe toxicities and modification to see whether or not they had any impact in outcomes. Interestingly, not only did the clinical outcomes look similar compared to those that had any dose modification, irrespective of region in the world, they actually looked like they may trend a little bit better. So, despite the toxicities that can be observed from this novel agent, it didn't impact clinical outcomes in a detrimental way. And so here's looking at some of the toxicities, comparing nab-paclitaxel with gemcitabine versus the triplet. The main side effect differences that we see with the triplet is really in gastrointestinal side effects, primary diarrhea, which has been known to be a common side effect with not only irinotecan, but with NALIRI. While with gem-nab-paclitaxel, we tend to see more of issues with cytopenias. My bias, typically when I give it off study, is usually to give it in a biweekly fashion, and I think if that was done, we may see some differences in the results, but nonetheless, these are kind of what the typical observed toxicities, with nothing new that wasn't previously observed from the NAPOLI-1, which is the second-line study. So let's stop here to go through some QR questions. the next slide. So this was a systematic review that was published in JAMA Network Open last year to hopefully provided some more further insight looking at the different first-line treatment options. And so they went ahead and did a systematic review looking at 7 phase 3 first-line studies, looking at studies that looked at nalirifox, FOLFIRINOX, and gemcitabine nab-paclitaxel. And the main takeaway from this study was that they showed no differences in clinical outcomes comparing both triplet agents, so both nalirifox, FOLFIRINOX, but both demonstrated survival benefit compared to gem nab-paclitaxel. And then when they looked at the toxicities, they saw a higher degree of cytopenias as well as peripheral neuropathy with gemcitabine nab-paclitaxel, while a higher incidence of more cytopenias and gastrointestinal side effects with the triplet. And so my take home really from this study was not only did it confirm that if a patient is a good PS and that you feel that would be appropriate to get a triplet, that would be the preferred option. Again, there's never going to be a study that compares nalirifox FOLFIRINOX. So I think both are really appropriate options in terms of those with the best PS. And we may decide also to give a triplet specifically with a platinum-based chemotherapy based off some of their genomic data that we may have available. But for those that potentially may be a PS borderline 2 or even questionable 3, then I think the doublet would be more appropriate. So let's go back to this case. And so again, patient newly diagnosed metastatic pancreatic ductal adenocarcinoma that hasn't been treated. Before we start talking about treatment, do you guys feel that any further ancillary testing should be conducted at this time? And so, I think the big take-home is really, which we're often seeing forefront with all of our patients, outside of certain malignancies, is the role for genomic testing. And so here's a slide from a study that was published about a year ago, where they looked at the integrating genomic testing as part of the treatment care for various solid tumor malignancies. And when we look at pancreas cancer, we can see that the proportion of patients that have either an approved therapy or clinical trials remains low, but we can see that proportion still being nearly 30%. And we'll talk about, over the next few slides about some of the new emerging therapies that not only have been FDA approved, but are on the forefront of the treatment landscape, and we may see some interesting developments shortly. So when you think about pancreas cancer, at least several years ago, we used to kind of think of it as kind of RAS mutant or RAS wild type, and that was kind of the end of discussion. But now our increased understanding from doing testing as well as studies that have been presented and published have demonstrated that there are potential actionable genomic alterations, again, approaching nearly a third of these, that affect nearly a third of these patients. The most notable one being MSI high, which which is very uncommon, about less than 2%. But BRCA1 and 2, based off the publication and FDA approval of olaparib for BRCA mutant pancreas cancer. But in those that with those are with KRAS wild type, we are starting to see some new targets that are notable, including NTRK, HER2 amplification, and BRAF. While we are starting to see some data to look at targeting these KRAS mutations, the one that we're probably most familiar with is KRAS G12C. We are starting to see some of these multi-RAS-on inhibitors that target some of these other codons as well. So when you look at the guidelines, not only do they recommend germline testing for patients with newly diagnosed pancreas cancer, but they are recommending upfront genetic testing. And so how do we do genetic testing? While tissue tends to be the gold standard, are we doing tissue, blood, or both? So when you look at molecular testing, really I think the gold standard still remains to be tissue. One of the challenges with tissue, especially in this disease, may be the access of tissues. So often when these patients are diagnosed, they often go and get an EUS where they may biopsy only the primary tumor. And oftentimes they're doing it through an FNA. So you only have an aspiration where you actually need core tissue to do this diagnostic testing. So oftentimes where we don't have tissue available, we're only limited to blood. And so I think that what we know from studies that have kind of validated the role for blood is that the sensitivity tends to be a little bit less. And we know that depending on the site of where the tumor or metastatic sites are, the shedding of the circulating tumor DNA may be less. But we know if you see actually a true positive test that it actually is there. It's not a false positive. But you may potentially be missing some missing some actionable genomic alterations, primarily with gene fusions. And so I think when you think about fusions, probably the one that's probably most notable is with NRG1, we'll kind of talk about the data and being pertinent not only in lung cancer, but specifically in pancreas cancer. And so I think this is where the role for tumor becomes, more highlights the gold standard of tumor tissue being what should be recommended. But oftentimes I usually do both, okay? And so, why is tissue better than blood? The main initial limitation with blood-based assay was the inability to do RNA sequencing, but we are starting to see some of these commercial blood assays included as part of the testing. And so, really with RNA testing, what you're missing is the unknown gene fusion partners for some of these fusion alterations, specifically, again, in this case, really NRG1. And so RNA tends to be a more comprehensive test because not only does it include the RNA part, but also includes the DNA sequencing. And we know it does a better job of detecting gene expression as well as some of the variants that are unknown. So if this was a quiz or test, you should do both, but really, again, tissue being the gold standard based off the ability to do RNA sequencing. And so the first agent that was approved that showed really kind of proof of concept and the role for genetic testing was the POLO study. And so this was a randomized phase 3 trial that looked at giving olaparib maintenance therapy in those that initially had a treatment response to platinum-based chemotherapy, in those with a germline BRCA-mutated pancreas cancer. And the study was positive. It met its primary endpoint in showing an improvement in progression-free survival. There was unfortunately no overall survival benefit. There are a lot of caveats to consider for this study, but this was really the first study that showed a potential benefit of looking at actionable genomic alterations in terms of the treatment for pancreas cancer. So this really was at the forefront at that time, the first study that was published and presented, and then we'll see some other interesting results as well. And so on the tails of that, we've seen a lot of data really with KRAS G12C. This was initially the study that was published and presented by John Strickler several years ago in New England Journal of Medicine, where and this cohort, they're specifically looking at pancreas cancer. Here we can see the objective response rate being greater than 20% in a heavily pretreated patient population with a median overall survival being nearly 7 months, just showing the potential role for some of these actionable genomic alterations with targeted treatment. Similar to these study results, we had the results published from adagrasib, which is another small molecule inhibitor that targets KRAS G12C. Here when you look at the data from the pancreas cohort, we can see the objective response rates being higher, being about nearly 35%, with a PFS being greater than 7 months. And so really the take-home from these two studies is not only is targeting KRAS G12C actionable, but it appears to be a relevant target in terms of how we manage and treat these patients. And so most recently, there's been a lot of interest in looking at these pan-RAS inhibitors. As we know, in pancreas cancer, the most prevalent KRAS mutation is in KRAS G12D. And so this data was initially presented last year, and we had saw updated results this year at ASCO GI. And so RMC 6236 is a pan multi-RAS on inhibitor that targets various G12, what they say G12X mutations. So not only does it target G12D, but also G12C. What they looked at was to look at various dosing, and this was the results from the phase 1 study where they started with a dose of 160 milligrams and where patients were titrated up to 300 milligrams. And they broke it down based off line of therapy. So here in the bottom, we can see patients in terms of PFS and those that got it in the second line setting compared to those that got in the third line beyond. And so irrespective of the line of therapy, we do see an improvement in compared to what we would consider very low, a bar, probably PFS about, I would say 1 to 2 months in the refractory setting. We can see the median PFS was greater than 8 months in those that got in the second line setting, and then greater than 4 months in those that got it in the third line setting. Similar to the previous results with the G12C inhibitors, we can see the response rates being greater than 20%. So very interesting to see these targeting RAS coming to fruition in not only clinical trials, but hopefully soon to our clinics. And so let's get back to the case. So upon genomic testing, both germline and somatic testing, we can see that the germline did not detect any pathogenic variants. And when you look at the DNA testing for look at somatic mutations, we noticed that the patient was KRAS wild type. And so what should we do? So circling back to our previous slides, ideally this patient should have had upfront RNA-based sequencing to look at potentially some of these fusion partners. Should we initiate triplet chemotherapy? Should we do a doublet therapy if we feel like the patient may not be a candidate to receive a triplet? Or always textbookly answer consideration for clinical trials. All right, so we can scan this QR question. So we ended up deciding to treat this patient with NALIRIFOX. Again, the patient was at appropriate performance status, so we had the option to give a triplet-based chemotherapy, and he initially tolerated very well. But at 6 months, while he's experiencing evidence of clinical response, he starts to have issues with neuropathy. He says that it's starting to impact his quality of life and his ability to perform his activities of daily life. And so one consideration he was asking is whether or not we can consider to discontinue oxaliplatin. So I'll stop here. Let me ask you, Nitya, how do you typically manage neuropathy in your clinic? What would you consider doing for this patient?
Yeah, so the tricky thing with treatment-related neuropathy is we know that when we stop the drug, the neuropathy is going to get a little bit worse over a period of a few months before it's going to slowly, hopefully, start to get better. So in a patient like this with advanced metastatic disease that's certainly getting benefit from NALIRIFOX, but starting to have a little bit more treatment-related neuropathy, now is really, at 6 months, now is around the time when I would think about dropping doxaliplatin and just kind of moving to maintenance 5-FU and liposomal irinotecan. And we can always potentially add doxali back in the future, but I would give the patient a break off doxaliplatin.
Yeah, I agree. I think, the challenges with neuropathy, as Nitya mentioned, is that once you kind of get to grade 2, we know that usually for these patients, it becomes irreversible, and especially in the setting where treatment intent is really palliative. I think understanding or being able to manage their impact on how it's going to impact their quality of life is really important, and so it's important to have that discussion with the patient. And so after discussing with the patient decides he wants to continue oxaliplatin. That's something that we may hear oftentimes with our patient. They're doing well, they're experiencing a good clinical response, they want to maximize it, so they said, let's just continue with it. If it gets worse, I'll let you know. Which, sometimes our patients don't disclose it as well, and so I usually have a frank discussion with them, letting them know that, that it's important for them to that we have a low threshold to stop it or dose modify it, so it's important for them to let us know. But in this case, Stephen decides that he's okay, it's not impacting his quality of life overly much, so let's just continue with the current plan. Okay, so let's move on to a second case. So this one's gonna be a little bit different scenario. So Brenda, she's a 68-year-old female with metastatic pancreatic ductal adenocarcinoma. She was initially started on gemcitabine-based regimen, and unfortunately, after several months, her scans show evidence of disease progression. So as part of our routine care, she did undergo genomic sequencing with both DNA and RNA-based platforms, and unfortunately, no molecular abnormalities were observed. So how would you proceed with sequencing treatment for Brenda? How does treatment in the first-line setting influence your decision-making in the second-line care and beyond? Okay, so first line, she got gemcitabine-based regimen. Now we're talking about what to do for the second-line setting. And so this is a busy slide, so I apologize, but just want to quickly highlight the key pivotal refractory studies in the second-line setting that were conducted in pancreas cancer. And the main take-home is that out of these 4 studies, the ones that truly showed a benefit were those on the one in the upper corner on the left. That was a Napoli-1 trial that looked at giving nanoliposomal irinotecan 5-FU. The study on the right, the GEM-PAC, was unfortunately negative. That was looking at gem-paclitaxel, so not gem-Abraxane, so gem-paclitaxel in the second-line setting. And then on the left bottom, that was looking at giving FOLFIRI veliparib. This was a cooperative group study that looked at adding PARP inhibitor to FOLFIRI. That was also negative. And then we had the study on the right that looked at giving an antibody in combination with gemcitabine nab-paclitaxel, which was also negative. So really, we only have really one positive second-line study. We also have the CONCO 005, which has some mixed results based off FOLFOX. So I think really when you think about the second-line setting, you have NALIRI with 5-FU, and you also have potential FOLFOX as an option. And so to get back to this patient, this patient was KRAS wild type. So we know that in patients that are wild type, which is only a small proportion of our patients, as we know that greater than 90% of patients have KRAS mutations, we know that in these patients, the incidence of having a fusion mutation is much higher. And so the notable fusion mutation that I think we're most focused on right now, not only being RET, given some of the FDA approvals, and NTRK, but now NRG1. So what is NRG1? So NRG1 is a partner that translocates through transmembrane domains, and it's next to HER3. And it binds to HER3 and causes the heterodimerization of HER2 and HER3 and leads to downstream activation of the MAPK pathway. And so initially, some early results in breast cancer showed that targeting NRG1 may be a potential target in terms of treating these solid tumor malignancies. And so zenocutuzumab, this study is now actually published in the New England Journal of Medicine, is a bispecific antibody that targets the dimerization of HER2 and HER3. Binds to the interaction between HER3 and NRG1 and prevents the heterodimerization between HER2 and HER3. And so here's some of the preclinical work showing the activity of how this drug works. So not only does it bispecific antibody, it also cause some antibody-drug complement cytotoxicity. And so here are the results that were published in the New England Journal of Medicine, the initial phase 1, phase 2 trial, where we can see that the objective response rate being over 40% in patients with pancreas cancer. Similar objective response rates are also observed in those with non-small cell lung cancer. And we can see that the majority of patients did experience some evidence of tumor reduction. And so in terms of safety and tolerability, the primary side effects that we tend to see with this drug is mainly gastrointestinal with diarrhea, stomatitis, and then some degree of fatigue as well. But otherwise, the treatment is very well tolerated with minimal grade 3 or grade 4 toxicities. And so other agents that have been active in pancreas cancers, probably most notably is BRAF V600E. So in the middle, this is the waterfall plot from the initial MATCH study that looked at the responses in the patient with pancreas cancer cohort. And then we also have looking at targeting RET fusions as well as FGFR fusions. So notably, just to highlight that, in addition to KRAS being targeted, we can, with the appropriate testing and sequencing, we may be able to identify some of these other actionable genomic alterations. And so just to quickly highlight, one last target is claudin 18.2. So claudin 18.2 is a junction protein that's prevalent most notably in gastroesophageal cancers, but also in pancreas cancer. And recently this drug was approved for the treatment of gastroesophageal cancer. There's been a lot of work looking at zolbetuximab, which is an antibody in combination with chemotherapy, and the study's being led by Dr. Park, Woonkie Park at Memorial Sloan Kettering. But there are also some other agents looking at targeting claudin 18.2, notably looking at adoptive T-cell therapy and bispecific antibodies. So this is an area or target that you may see some more news on. I know there's some data being presented this year at ASCO as well, but it's just something to note in the back of our minds. Okay. And here's some of the initial results from IB1398, looking at a bispecific antibody in the refractory setting. And here we can see the objective response rates being nearly 30% in those that were claudin 18.2 greater than 10%. But when you look at the IHC, if it's greater than 40%, we can see the objective response being more heightened. So very interesting, which we'll continue to see more emerging data. So in summary, unfortunately, pancreas cancer, despite it being a very difficult malignancy to treat, where chemotherapy remains the mainstay, we are seeing some emergence of some new treatment options, notably with targetable therapies. In those that are appropriate candidates, triplet chemotherapy, whether it's NALIRIFOX or FOLFIRINOX, should be the preferred treatment option for these patients. And upfront molecular testing should be done. While in the past we used to kind of think of pancreas being a very genomically bland disease, we can see that with appropriate testing, we may be able to identify patients who may benefit from some of these novel targeted treatments.
Okay, so we have some time for some questions. We've received some already online, and again, I'll encourage people to feel free to, both in-room learners as well as those at home, to be able to use the QR code to answer some questions. We've got some questions already. Maybe Daniel, since we're talking about pancreatic adenocarcinoma, I'll start with you. One of the questions we've asked is asking about, you outlined some of the testing, especially the NGS, the DNA and RNA. Are there other tests you think that are promising that are going to help us advance the field of pancreatic adenocarcinoma?
So if we're talking about the role for looking at circulating ctDNA or MRD, I think that still remains, I would say, experimental. In terms of the primary use has been really looked at in the early stage disease, but we are now considering looking at using it as a way to assess treatment response. I think most of the data is really with immunotherapy, but I think right now for the forefront, I think, just NGS testing, whether for both blood and tissue, kind of remains, I think, kind of the standard.
And if we were to expand the role of ctDNA, would that help, do you think, guide therapy, or simply help in terms of understanding our prognosis and maybe the aggressiveness to which we need to treat our patients?
Yeah, that's a great question as well. So I'm kind of been one that doesn't use it as frequently across all the diseases I treat. I think it's more prognostic. It's not something that's really predictive as a biomarker for treatment response. So I think that's kind of where the role is right now at this time.
Great. Moving on, we'll go back to neuroendocrine tumors and carcinomas. One of the questions we have is the difference between G3 net and G3 NEC, especially on small biopsies. And they wanted us to comment on the difference in treating G3 net and NEC. Nietzsche, do you want to start with that?
Yeah, sure. I think that's a great question. And so I think really the important thing to emphasize here is that G3 net is truly different than G3 NEC. So G3 NEC is poorly differentiated neuroendocrine carcinoma, which is a different disease with a different set of therapies, and G3 NET falls under your umbrella of well-differentiated neuroendocrine tumors. So the therapies we talked about tonight. So when we think about poorly differentiated neuroendocrine carcinomas, or G3 NEC, our mainstay of therapy is really platinum-based chemotherapy. There is a lot of work and energy going in to try to identify alternative treatments for that disease. I think some was presented today. There's a lot of work going into ways to make immunotherapy more effective in that disease. But the therapies we talked about tonight, the targeted drugs, PRRT, somatostatin analogs, are not applicable to poorly differentiated neuroendocrine carcinoma. One point I'll make, and what can be tricky, and I think why it can be very confusing, is rarely we can see transformation of the disease. So, it's described, it's not that common, but it is possible for well-differentiated neuroendocrine tumors to transform into poorly differentiated neuroendocrine carcinoma. And that's typically something that you'll see the biology change, and we need to confirm with a biopsy and tissue sampling.
And then in G3 net, do either one of you, Daniel or Nietzsche, do you have an approach you take? This is a fairly new, we're not even 10 years into having this described as an entity, and already now we've had 2 successful possible treatments between NET-2 and the CABINET trial that both looked at G3 net. Do you have an approach you take when you see a G3 net patient, whether it be from GI or pancreatic origin, either one?
I often kind of look to the similar things we discussed earlier as really a symptomatic burden of disease. If they're very indolent disease, or if they're patients are much older and they're doing fine, I often start these patients on an SSA as my preferred first line. But if a patient is very symptomatic, then I think you have to be something more aggressive where you can get a response, such as looking at a radionucleotide or even chemotherapy.
Yeah, I would say that my approach to treatment is very similar, and I really look at the patient in front of me and their clinical symptoms, and then the imaging, the disease burden to guide that. Again, I think even for well-differentiated grade 3 disease, you really want to try to take advantage of all the therapies that you have. And so sometimes in the patients where the Ki-67 is closer to 20% on the lower end of that grade 3 spectrum, if they're fit, they're healthy, they're totally asymptomatic, relatively low tumor burden, I will give a somatostatin analog and certainly can get clinical benefit in disease control before jumping to some of the other therapies. But if you need a quick response, chemotherapy is something that I'll lean on early. And if you need a response but you have the time to get PRRT started, then I think that that's a great option.
One of the questions that I'll maybe comment on here is asking, we didn't talk a lot about pulmonary neuroendocrine tumors, and unfortunately that's often the forgotten group of tumors. As a single organ system, actually the most common type of neuroendocrine tumors, about 25% of neuroendocrine tumors are lung neuroendocrine tumors, and they're rising in incidence as well. Previously, we haven't had a lot of treatments for lung neuroendocrine tumors. For those, about 40% or so are SSTR2 positive. There was a trial called the SPINNet trial that tried to look at lanreotide compared to placebo for these patients. Unfortunately, it couldn't accrue and had to be stopped at 77 patients. So we did have some single-arm study, data, that did show maybe in those typical versus atypical that there was some benefit. But really, hadn't had a lot of data around lung neuroendocrine tumors. Radiant 4 included lung neuroendocrine tumors, and in fact was approved for that basis. And until recently, that was really the only treatment we had for lung neuroendocrine tumors. One of the really promising parts, I think, about the Cabinet trial was the inclusion of lung neuroendocrine tumors and giving us another option. Because I really find for my lung and thymus neuroendocrine tumor patients, I run out of options quickly. Sometimes somatostatin analogs, you try it, it's on the NCCN guidelines, but certainly there's not randomized evidence. And as I said, more than half are not SSTR positive. You try everolimus, the toxicity can be difficult, and then you're really left without options. So that's one really new, exciting area. I don't know if you wanted to comment on that, Nitya.
Yeah, I totally agree. I think that now having cabozantinib, it's a very, very important tool to treat the neuroendocrine tumors of lung and thymic primary, and often we can see a little bit more of an aggressive biology even in kind of the well-differentiated lung nets. And so actually, sometimes, I too will often try a somatostatin analog, but you're not going to subject someone to PRRT when it's clearly dotatate negative. And so in the ones that are kind of growing a little bit more quickly, I'll go to cabozantinib actually preferentially over everolimus.
And it's a good point. For those that are SSTR positive, we do have an NCTN trial going on currently looking at that to see if there's a role for lutetium dotatate in LungNet as well as in retreatment, but also there's a Spanish study as well going on. So we might see the growth of lutetium dotatate in LungNet as well. Well, there's a couple more questions, but we've run out of time and we've had a really great discussion. So I'd like to thank everybody at home as well as in person for their participation. Thank you so much. Again, thank you to PeerView for putting this on, and you could see here that they have, you can get credit if you go to the website for the questions that you answered, as well as download the slides and the practice aids. A specific thank you is to NCAN and to WIN for partnering and to really all the support they do for patients, as well as working with clinicians like us to help improve the care of patients with neuroendocrine and pancreatic adenocarcinoma. Thank you.